great technology, unique technology in the U.S. So definitely an exciting panel today. So up first, we've got Dr. Munjed, and he's going to talk about the Australian osseointegration experience.
Thanks very much, George. Good afternoon, ladies and gentlemen, and thank you very much for having me here. I'm no way an expert in this field, but I'll start because of alphabetical order. So I'll talk about my stuff-ups in this talk. I do have financial disclosure because I do design the implant and a few others related to hip and knee surgery that's not related to osseointegration. So far we have done 330 cases in Sydney, Australia. The majority of them are single-stage osseointegration surgery, and we have done 82 two stages. We still do every now and then two-stage surgery for very, very complex cases. Majority of our patients are males, and Australia represents the largest cohort of patients so far with the group that we worked on, but the United States represent the second largest cohort. We have done 67 American cases, basically. And you can see the distribution in Australia: New South Wales, Queensland, followed by America. The distribution in the United States is from pretty much everywhere. Majority of them are from Texas and California. Canada is important because if you guys are going to go north and invade that country, so you need to know about it. So we have done 18 Canadians as well. We started very slow. In 2010, we did one case, and then the next year we did 4, and then from there the pace picked up once we become more comfortable that the outcome is satisfactory. Majority of our cases were traumatic amputees, but we have done 17 vascular amputees, and we're watching these very closely because that's a contraindication for osseointegration with the agreement of most of the groups. Funny enough, the vascular amputees that we treated, they all so far have been doing really well, which is interesting. Transtibial amputees, we have done 90 cases, and again, majority of them are traumatic, but you have deformity, infection, cancer, and 10 out of the 17 vascular patients are transtibial amputees. The reason we did them is not to convert them to above-knee amputees, and that has been working so far. We have done a large number of bilateral amputees as well, but still the unilateral above-knee amputees represent the largest number of cases. We have collaborators around the world, and the number of centers that are taking on our protocols and pathways increasing. And Holland is the largest group, but we have other groups in other places. And that put the number to 463 cases so far done worldwide. Looking at the proportion of patients who took on the osseointegration, that's 2-year follow-up. Wheelchair-bound patients were the minority, which is opposite to what people expect. Obviously, majority of patients who are wearing a socket, they do have socket problems, but we have done the osseointegration cases were mobile, basically. And looking at transtibial amputees, I don't know, correct me if I'm wrong, you've done 13 tibias from the last paper you presented, but I might be wrong. But the other groups have done 10 in Germany and 5 in the Netherlands with transtibial amputees. Type of implants that I used 2 systems. The one system is German implant, which is called the ILP, and the other system is made in Italy and has 3 types: type A, type B, and type C. And you can see that type A is the largest number of cases that I've done, and that's because majority of the cases that we're dealing with are long-term amputees with significant osteoporosis, and type A provide a collar fixation and large osseointegrated porous surface that allows the better contact surface, the optimal contact surface for these kind of patients. We have done variety of cases. Femoral osseointegration 228, tibial and 80, But if you look at the osseointegration with total knee replacement, osseointegration with total hip replacement, as well as limb lengthening with osseointegration, that divide them into other subgroups, basically, and these are very complex kind of cases. So the percentage-wise, still OPL represent the largest number of cases that we have done, which is titanium implant, as opposed to the chrome cobalt implant, which is the ILP. If you look at the size distribution of implants that we have used, the larger the proportion of patients lies between 16 and 19 millimeter in diameter. That gives you an indication that these patients are osteoporotic, because as an amputation occurs, the femur dilates with time, and because an intact femur in an adult, the diameter of the canal is less than 14 millimeters normally, on average. You can see that the size of the dual cone, which is the transcutaneous connector that we use, largely we use size 1, and that indicates that our soft tissue management is extremely suggestive that we remove as much soft tissue as possible to minimize the risk of infection. Basically, we remove all the subcutaneous fat. Now, talking about reoperations and problems, we have reoperated on 85 times. We reoperated on people. A lot of these are multiple operations. So wound debridement in 19 cases, neurectomies in 13 cases, refashioning is 26, revisions 19, bone fractures in 8 cases. The total number of patients that we operated on is 58 patients. We talk about the revision of implants. We revised 10 femurs, okay, and 3 of them were failure to integrate because of my technical error. I undersized the implant, and the implant didn't heal, or the bone didn't heal on the implant. We had 4 aseptic loosening. We had 1 failure to integrate because I tried on a radiated bone, and it is a contraindication, but there was a special circumstance of a patient who didn't want to have shortening, and he was happy to take the risk, and I can show you that if I have time. And we had 2 cases that fractured their implant basically in that cohort. When we talk about the tibial revisions, we revised 8 tibias. 2 of them were due to infected total knee replacement with osseointegration. 3 others were due to septic loosening and infection, and 2 others were aseptic loosening due to overuse and high impact activity, and 1 was failure to integrate, basically. When you look at the reoperation rates in patients, which were 58 patients, it was very interesting results. There were 29 each side, single stage and 2 stages, and that makes it very interesting that the revision rate of surgery, this is to date, of course, and the argument and the criticisms that I will take as a result of that is because I don't have the 2-year follow-up now on these 2 cohorts, because some of them have been done just recently. However, if you look at the data is damning. Single stage surgery, we have only 12% failure and reoperation rate, while 2 stages were 35%. And majority of it is due to refashioning and wound debridement. When you look at the rate of reoperation, again, the numbers are very even between single stage and 2 stages. And the 2-stage surgery, reoperation rate was 52% out of the reoperation rate altogether, while the single stage was only 17%. So when we did implant revisions, again, we looked at the 2-stage surgery, there were 7, but single stage were 11. And that, again, makes it lower on the single stage surgery. It's 4% of revision rate. If you look at the implant removal total, where 8 in the tibia and 10 in the femur. So we had revision of 18 implants out of 226 cases, basically. The implant removal rate in the femur is 4.2%, while in the tibia is 8.8%. So still transtibial amputees have much higher risk of losing their implant than the transfemoral amputees. And when you look at it between the single stage and 2 stages, which is, I don't think it's much relevant, the implant revision rate on the femur is 2.4%, so it's very low. Okay, so I can say clearly that it's transfemoral amputees. I know it's a lot of jargon, a lot of numbers, but statistically speaking, it is safe to do transfemoral osseointegration. That's the safest, basically, because you can see that the revision rate is very low in this group. So I don't think I have enough time, so I might just cut it there. Okay, I'll let you go. No. Yeah. Huh? I have 10 more minutes. I'll take you through some X-rays. Okay, we had 9 fractures, 9 neck of femur fractures, actually. So we can see this first patient. That's my second patient I did, and she was in rehabilitation as she was standing, and that's why this lady was 31-year amputee, wheelchair bound. We did an osseointegration for her. We stood her up. As she was standing, she broke her neck of femur. Basically, after a few days, so she had a fracture while she was in rehab, and that's why I'm very strongly suggesting that people should be gradually loading rather than loading immediately, unless they are obviously very healthy, very young, and very recent amputees. You can see this. This is after I fixed her hip. She's my second patient. She's 6 years plus now, and managing reasonably well. She's overweight, but she still have problems with soft tissue. The second one is another female patient. She's my 5th patient, and she fractured her hip again 6 months down the track, but as a result of a fall. None of these 2 needed removal of implant. The third patient was a patient that had a fall again in rehab. Funny, these first 3 patients, they had fall in rehab, and he was number 38 patient basically, he's the first diabetic that I did. This patient is a bilateral amputee. She's American, and she had a traumatic fall. She fell off a boat. And she fractured her femur. Unfortunately, I don't have the X-rays. I don't know where I kept them. The other patient was playing croquet and he slipped on a ball and he landed on his hip and he fractured his neck of femur as well. Another patient who had he's from the UK, and again he fractured his neck of femur. You can see all of these patients have broken their neck of femur. This is another complex patient. He's a cerebral palsy patient on the other stroke patient on the other side, very short femur, and he fractured his neck of femur 6 months down the track. All of these patients have been fixed without needing to remove the implant, but fractures do happen with these patients. Revision cases, 18 in totally. I had 2 breakages of implants, and both implants were manufactured by Orthodynamic from Germany, and both implants were size 15, and they are chrome cobalt implants, and both of them failed at 3.5 years, and both patients were very high active K4 level activity and very heavy weight. You can see this is the first patient. He's a New Zealand farmer, and his body weight is significant, and he was a recent amputee, so we couldn't put a large implant in him because his femur was very strong, so we had to compromise, and he carries very heavy weight normally, and He had a fall 2 years after the surgery, and he bent his implant, but we didn't know about that. And then the implant fatigued at 3-year mark, and the implant was removed. What's interesting, you can see the amount of osseointegration that this patient developed, and you can see the bone growing on the implant. So we have this special device, a coring device, that we cored the implant and took the proximal part out, and you can see that's what the implant looks like, the broken part in the area where it fatigued. We removed the implant and we just left the wound open, and the wound closed within 6 weeks, and then we re-implanted him again with much bigger implant, and that's in 2015. He's doing extremely well. So he didn't have to have any shortening or any problems, and that's him walking after the re-implantation. The second patient is a very complex patient. Despite of his complexity, he lost his limb at the age of 4, and you can see his femur never grew up. Interestingly enough, he is an elite athlete. He has, I think, 9 or 11 world records in his name in Paralympics, and his femur was extremely narrow, so we had to modify his femur. I did an osteotomy of his femur and did bone graft, and then inserted a long implant for him with cabling, and that's him walking after the surgery straight away, basically. And then he jumped off a roof 5 meters high, and then he rang me and he said, "Well, I can't walk." He did an X-ray and showed that the implant is bent inside. But when we did a CT scan, you can see that there is a crack in the implant, and he was trying to walk on a broken implant, basically. So we took it out. I haven't reimplanted him yet, but he's booked in the coming week or two. That just happened recently, basically, and we managed to get the implant out without damaging his femur. And what's interesting is that his femur canal has become cylindrical, which is very good. Infected knee replacement with osseointegration. This is my biggest failure, and as a result of that, I stopped doing knee replacement. I have done 9 knee replacement with osseointegration so far, 2 of which I revised to above knee. And I don't know why some of them worked and some of them didn't. So this is one case where I did an osseointegration device with a knee replacement. You can argue that the tibial component is extremely large, and then we had to convert him to above knee after an infection. He's an Australian patient of British origin. He lost his limb in the war. He's a sniper, and he's a very, very straightforward guy, no bullshitting. And when he got an infection, he didn't even want to bother. He said, "Just take it off," because we've been thinking about taking my knee off like 30 years ago, because he had severe arthritis and his knee was destroyed beforehand. So we moved him to above knee, and he's done very well so far. The second patient is a patient that I did in 2013. He did very well for 4 years, and then very recently he got an infection in the knee, and you can see in front of the tibia, the proximal end, there is loosening, a lucency sign, but it was septic. Funny enough, he was never on antibiotics, and he never grew a bug. But it was clearly there is a sign of infection. He had pain, he couldn't walk, his knee was very swollen. So we moved him to above knee, with osseointegration, and he's fine. I had a few breakages of the dual cone, the connector, and they are pain in the butt to remove. We had 5 cases, mainly in very active, very high impact patients, and to remove them, it's really very difficult because they cold weld, and we're trying to solve this problem by getting different material in the connector, because if they cold weld, and you can't remove them unless you burn them out. and I had to burr out one just 2 days ago for one of my patients. This is a patient we had to put a thread on top of it and try to pull it. That's the latest patient that I just did here in this hotel, and tried to remove it. It was impossible. Then I had to burr it out, and eventually we managed to get it out. Basically, I better stop here. Yep. Okay. I can go on the list. It's very long.
All right. Thank you, Dr. Medeiros. And now it's time for our next speaker,